Thyroid disorders. Let's first study hypothyroidism. Before diving into it, let's see the basic physiology. The HPT axis, that is hypothalamus, pituitary and thyroid axis. As you can see, the hypothalamus produces TRH, that is thyroid releasing hormone, which stimulates the pituitary to produce the TSH, that is thyroid stimulating hormone. The thyroid stimulating hormone reacts to the thyroid gland and causes the thyroid gland to produce T4 and T3. This is the thyroid hormone. Now let's see how this thyroid hormone is synthesized inside the thyroid gland. As the iodine reaches the blood, it is uptaken by the thyroid gland and it is converted into negatively charged ion by an enzyme TPO, that is thyroid peroxidase. This thyroid peroxidase helps the iodide formation, and this iodide along with Tg, that is thyroglobulin, combines and forms the thyroid hormone. This thyroid hormone is poured into the blood and is transported to all the body tissues with the help of TBG, that is thyroid binding globulin. Now this whole process is governed by an enzyme, that is TSH, which is basically a hormone released by pituitary. This hormone is acts on a receptor, TSH receptor, and regulates the hormone synthesis. Now let's see the role of thyroid hormone in our body. The thyroid hormone is required by every cell of the body for its metabolism. It regulates the BMR, or the basal metabolic rate. It stimulates the RNA synthesis and the protein synthesis. It is also required for glucose, cholesterol, and protein metabolism. It is also required for the heat production by thermogenesis. Now let's see the hypothyroidism, the definition. It is taken from the Nelson book, 21st edition. Let's see the definition. Hypothyroidism is a state of insufficient circulating thyroid hormone. The deficient production of thyroid hormone caused either by a defect in thyroid gland itself, that is primary hypothyroidism, or by a reduced thyrotropin stimulation, TSH, that is the central hypothyroidism or the secondary hypothyroidism. Hypothyroidism may be present from birth, that is congenital hypothyroidism, or may be acquired, that is acquired hypothyroidism. Now let's see the most important topic of today, congenital hypothyroidism. The congenital hypothyroidism is the most common preventable cause of intellectual disability. The incidence has increased probably since improved testing strategies. The incidence in India is 1 in 1100, and in developed countries like USA it is 1 in 2000. Female to male ratio is 2:1. The congenital hypothyroidism may be associated with trisomy 21, congenital heart disease, other congenital malformations like cleft palate, renal, skeletal, and GI anomalies. The causes of congenital hypothyroidism are divided into three major broad groups, that is permanent congenital hypothyroidism, transient CH, and hypothyroxanemia with delayed TSH elevation, which is atypical CH. Now the permanent congenital hypothyroidism are of four types, that is thyroid dysgenesis. The thyroid dysgenesis is the most common type of permanent CH. It comprises of 70% of the total permanent CH. It includes agenesis, hypoplasia, and ectopic. It is almost always sporadic and it is rarely associated with genetic mutations. The clinical features include no goiter, low total or free T4, increased TSH, and normal TBG, that is thyroid binding globulin. The thyroglobulin level reflects the amount of thyroid tissue present, and if low, it indicates the agenesis of the hypoplasia. USG tells the presence or the absence of normal located thyroid gland. The investigation of choice is the scintigraphy by RAI, that is radioactive iodine uptake, or the pertechnetate, which is the investigation of choice as shown in these diagrams. Now let's see the second type of permanent CH, that is thyroid dyshomogenesis. It is a defect in thyroid hormone synthesis or its secretion. It is the second most common cause of permanent CH and it involves the abnormal TPO activity. The clinical features include the goiter, which may be present or absent, total and free T4 is low, TSH is elevated, and the TBG is normal. The thyroid imaging is normal since it is an intrinsic enzyme defect. Now coming to the third type of permanent CH, which is TSH resistance. In this, there is mutation in TSH. Now let's see the fourth type of permanent CH, that is central hypothyroidism. As the name indicates, it involves the HPT axis defect. The clinical features mainly involved are goiter is absent, TSH is low, T4 is low, and the TBG is normal. In this, one must remember that cortisol and GH, that is growth hormone level, must be measured because it indirectly indicates that there is some defect in pituitary. Also, we must perform MRI brain to visualize the hypothalamus and the pituitary. Now coming to the second broad category of the causes of congenital hypothyroidism, that is the transient congenital hypothyroidism. It is of 6 types. The first is anti-thyroid drug. In this, there is an history of maternal intake of anti-thyroid drugs, because of which there is an intrauterine exposure to methimazole or propylthiouracil. Second cause may be iodine excess. The iodine excess is the most common cause, being the topical antiseptic overuse, like seen in this. The radiographic contrast, the mother eating large amount of seaweed like in Korea. The mechanism behind this being explained by Wolff-Chaikoff effect. The clinical features include goiter, which may be present or absent, the T4 which is low, TSH is increased, and the USG shows the normal position but enlarged gland. Now coming to the third type of transient congenital hypothyroidism, in which there is an iodine deficient mothers. Let's see the fourth type of congenital hypothyroidism, that is THOP, transient hypothyroxemia of prematurity. It is associated with ELBW or extremely premature children. As can be seen in this diagram, as the fetus grows, the thyroid gland matures. If a child is delivered prematurely, then it is likely that thyroid production is not enough. But as the fetus or the neonate grows, the thyroid production increases. Hence, it is a transient phenomenon. In this, there is low T4, normal TSH, and immature HPT axis. Now let's see the fifth type of transient hypothyroidism, that is TSH receptor blocking antibodies. As the name indicates, in this there are antibodies which prevents the TSH from acting. It is seen if mother is having autoimmune thyroid disease. In this, the IgG from the mother crosses the placenta and remains in neonate up to 2 weeks. The hypothyroidism caused may persist up to 2 to 3 months. The clinical feature includes goiter, which is often absent, the T4, which is low, TSH increased, and TBG normal. Since the hypothyroidism is persisting for 2 to 3 months, hence, although being transient phenomena, it may require treatment. Now let's see the last type of transient hypothyroidism, that is the sixth type, large liver hemangioma. It is basically there is an increased expression of thyroid inactivating D3 enzyme by the hemangioma, which basically inactivates the active thyroid. Let's see the third and the last category of the cause of hypothyroidism, that is the atypical congenital hypothyroidism, which is hypothyroxanemia with delayed TSH elevation. It is often associated with ELBW or the VLBW neonates, that is the premature neonates. The initial days there is low TSH and low T4, but gradually they come to normal level. Now let's summarize all the things we have learned so far and also relate them with the lab diagnosis and further management. The permanent congenital hypothyroidism. Out of the 4 types, the first type is thyroid dysgenesis. The total T4 is low, free T4 is low, and the TSH is high. The thyroglobulin here is low, and on doing the thyroid imaging, we see that the thyroid gland is absent or small. Treatment, yes, it requires the treatment, and it is almost always sporadic. The thyroid dyshomogenesis is in this, the T4 and the free T4 is low, TSH is high, the TG may be present or absent, thyroid imaging shows normal or enlarged thyroid gland, and the treatment, yes, it also requires treatment, and it is usually autosomal recessive. Now coming to the TSH resistance, again the T4 and the free T4 will be low, or it may be normal. In this case the TSH is high, the TG is low, and the thyroid imaging states normal. Since it being a mild phenomena, hence it may or may not require treatment, and it requires treatment only in cases of severe. Now coming to the fourth type, that is central hypothyroidism. In this the T4 is low, free T4 is low, and the TSH is also low. The TG is also low, and the thyroid imaging shows normal since the defect is in the pituitary. And it is often usually missed in NBS because the TSH is low, and in NBS we do TSH screening. Now coming to the transient CH, the transient congenital hypothyroidism, the first type is maternal anti-thyroid medication, in which again the T4 and the free T4 will be low, the TSH will be high, the TG is normal. Since being the transient phenomena, it does not require treatment and subsides by 1 week. The TSH receptor blocking antibodies, again the total T4 will be low, free T4 will be low, and the TSH will be high. And this may require treatment because, as we studied, that this may persist up to 2 to 3 months, hence may require treatment. The THOP, that is transient hypothyroidism of prematurity, again in this the T4 will be low, the TSH will be normal. It is important to note that TSH will be normal, TG will be normal, and thyroid imaging will also be normal. Hence it is controversial for the treatment. Iodine deficiency, if it is iodine, if there is decreased iodine, then the TSH will be high, and the treatment being the iodine supplements. And how we diagnose it? We diagnose it by measuring the urine iodine, and it is decreased in iodine deficiency, whereas in iodine excess the urine iodine is increased. In TBG deficiency, again the total T4 is low, the free T4 will be normal, and TSH will also be normal. It is very important here to note that the total T4 will be low, but free T4 will be normal. This is a transient phenomena, hence it does not require much treatment. Now coming to the last part, that is liver hemangioma. Liver hemangioma, the T4 will be low and the TSH will be high. Since there is active degradation of the thyroid hormone, hence it requires large doses of levothyroxine. Now let's see the diagnosis of hypothyroidism. The congenital hypothyroidism requires the NBS screening, that is newborn screening. In this, both T4 and TSS should be measured in all the cases for infants in NICU or significant family history. The cord blood sampling from the placenta end can be used for screening CH, since has the advantage of being free from the neonatal TSS surge, which usually occurs after birth. But the cord blood has a disadvantage of being not suitable as a screening tool for other congenital diseases such as CAH, or the congenital adrenal hyperplasia, or the IEM, that is inborn error of metabolism. Hence, for universal screening purpose, heel prick sample, that is DBS test for all the newborns at 48 to 72 hours of life is recommended. The DBS at neonatal screening. The DBS is dried blood spot. It is basically heel prick sample from the lateral edges of the foot, as can be seen in these pictures. The filter paper with dried blood spots is punched. The advantages of DBS is that it is easily stored and transported. Same sample can be analyzed for metabolic diseases. Disadvantage of DBS is that it requires expertise in collection. The false positive if the sample is taken during the neonatal TSS surge. The availability issue of the specialized filter paper is also a big problem. Now, the cord blood sampling is preferred in some centers in India as it is easy, early, and effective. That is easily taken, early results, and effective outcome. That is free from TSS surge. The cord blood is a serum, whereas DBS is a whole blood. Hence, the TSH values in both will vary for declaring a child for congenital hypothyroidism. The serum TSH units is 2.2 times the whole blood units. Hence, if a child is declared as a hypothyroid in by using DBS, then the value of TSH will be 2.2 times less than the serum values. Now let's see the approach of newborn screening. The heel prick or the cord blood TSH is done on the first screen. The values may come as more than 20 milli international unit per liter in serum units, or the value may come as less than 20. If it is less than 20, then it is normal. But if the value is more than 20, it may be more than 80, more than 40, or between 20 to 40. If the value is more than 80 or if more than 40, then we straight away start the treatment and preserve one sample for confirmatory testing. Whereas if the value is between 20 to 40, then we repeat the TSH, usually within 7 days. If the child is less than 2 weeks of life, then TSH is more than 20, then it is significant. And if the TSH is more than 10 in a neonate more than 2 weeks of life, then it is significant. Now let's see. Um, Now we further test by using a confirmatory venous sampling for TSH, and free T4 is also done. Again, three results may come. If the normal T4 comes and the high TSH comes, then we repeat TSH after 2 weeks. And if the TSH is less than 10, then it is normal. But if it is more than 10, even after 2 weeks, then we have to start the treatment. But if at any point there is low T4, irrespective of TSH, then we straight away start the treatment and also perform the imaging studies. But if there is normal T4 and the normal TSH, then nothing to worry, it is normal. One must note any neonate with abnormal screening results should be evaluated further, and a consultation with a pediatrician is recommended. Maternal and family history should be reviewed and thorough physical examination should be performed. Now let's see another topic, acquired hypothyroidism. The acquired hypothyroidism is basically seen in 0.3% of the school age children. There are many subclinical cases which are diagnosed as elevated TSH with normal T4. The most common cause being autoimmune thyroid disease. It is more commonly seen in females as 2:1 ratio, and it is common in adolescence but can be present any time in the childhood. Etiology, mostly it is autoimmune. In autoimmune, it can be chronic lymphocytic thyroiditis, that is Hashimoto's thyroiditis, or it may be APS, autoimmune polyglandular syndrome. It may be associated with celiac disease, or it may be associated with type 1 diabetes mellitus. Hence, in these patients, the screening for thyroid disorder is very important. It may be drug induced, like taking excess iodide, which may be in diet or in drug like amiodarone. It may be because of anticonvulsants like CBZ, phenobar, valproate, phenytoin, or it may be because of anti-thyroid drug like methimazole and propylthiouracil, or it may be because of post-ablated, that is irradiation, radioactive iodine, or thyroidectomy being done. Systemic infiltrative disease may also be show hypothyroidism. Central hypothyroidism, in which HPT axis defect, tumor, trauma, or meningoencephalitis may also show this. Now let's see the clinical features of hypothyroidism. The clinical features can be very well understood by this diagram. There is open posterior fontanelle, dry hairs, narrow palpebral fissure, broad nose, edematous facies, large tongue or the macroglossia, the scaly skin or the rough dry skin, the protruded abdomen, the prolonged jaundice, umbilical hernia, the constipation. Hypothermia or unexplained cold intolerance may also be seen, or in neonates, hypotonia may also be present. As can be seen in this photo taken from Nelson, uh, you can see the coarse facies, the edematous face before the treatment, and after the treatment it has been reduced. Another pic from Nelson, the congenital hypothyroidism showing in a child the skeletal dysplasia, in which there is epiphyseal dysgenesis, as can be seen here. Another case from the Nelson only, the 21st edition, showing the acquired hypothyroidism in a girl of 6 years of age. She was treated with a wide variety of hematinics for refractory anemia for 3 years. She had almost complete cessation of growth, constipation and sluggishness for 3 years. The height age was 3 years, the bone age was 4 years, and she had a swallow complexion and immature facies with poorly developed nasal bridge. The serum cholesterol level was also high, and after therapy for 18 months we noted that nasal development occurred, increased lusterless in the hair occurs, and there is also maturation of the face. The height age was improved to 5.5 years, the bone age was 7 years, and there was overall improvement in the general condition of the child. Another case taken from the Nelson only shows a child of 12 years old boy with hypothyroidism has a short stature and generalized myxedema, sleepy expression, protuberant abdomen, and coarse hairs. The body proportions are immature for his age. The same boy, 4 months after treatment, his height age increased by 4 cm, and there is marked change in the body habitus owing to the loss of myxedema and the improved muscle tone and the bright facial expression. Another picture summarizing the hypothyroidism effect in an adolescent girl: the obesity, intolerance to cold, depression, hair loss, slow heartbeat, constipation, menstrual changes, fatigue, and or joint pains. Now let's see the treatment. The treatment of congenital hypothyroidism. One must note the optimal neurodevelopment outcome depends on early and adequate treatment of congenital hypothyroidism. The levothyroxine is started at a dose of 10 to 15 microgram per kg per day, and higher doses may be required for lowest T4 and highest TSH levels. Goal is to normalize the thyroid hormone level as soon as possible. The regular monitoring of free T4 and TSH levels are required. The blood sample to be collected before or at least 4 hours later thyroxine administration. Periodic growth and neurodevelopment assessment and the hearing test must be done regularly. Target. Our target is the rapid normalization of thyroid hormone levels during the first year of life, which leads to better outcomes. Ideally, T4 normalizes within 1 week and TSH normalizes in 2 weeks. Hence, first examination is done after 2 weeks of starting treatment. The 2 weekly follow up until FT4 or the free T4 and the serum TSH becomes normal. Later, every 2 monthly follow up until 1 year of age, and after 1 year, every 3 monthly follow up until 3 years of age, and after 3 years, every 6 monthly follow up is done. In case of any increase or change in dose, repeat testing after 4 to 6 weeks is performed. One must note, if the thyroid function test, that is free T4 and the TSH, are not normalizing despite treatment, then consider non-adherence to the treatment as a major cause. Now, how to give medicine? Only tablet form is available. Hence, levothyroxine tablet should be crushed and fed directly to the infant. Tablet can be mixed with small amount of juice, water or breast milk. Note that iron or the calcium supplement should be given at least 2 hours apart from the levothyroxine dose. The patients with transient congenital hypothyroidism, uh, in these patients, the trial for off medication can be attempted at 3 years of age, since thereby thyroid hormone dependent brain development is mostly complete. Note, the infants with transient congenital hypothyroidism usually does not require increase in dose of thyroid hormone with increase in age as compared to the permanent CH patients. Treating older children. Now, treating older children of the acquired hypothyroidism is basically there is dose is age dependent and the weight dependent. As the age increases, the dose per kg decreases. As shown in this table, the age 1 to 3 years, that the dose is 4 to 6 microgram per kg, and for the age of 3 to 10 years the dose is 3 to 5 microgram per kg, whereas for dose for 10 to 16 years the dose is 2 to 4 microgram per kg. The treatment should be monitored every 6 monthly by measuring TSH only. But if the child is less than 3 years, we have to measure both TSH and T4. During the first year of treatment, the deterioration from the schoolwork, poor sleeping habits, restlessness, short attention span, and behavioral issues may develop. But these issues are transient only. Hence, they are managed by counseling and starting at low dose and gradually increasing the dose of levothyroxine. Now, coming to the prognosis, there is excellent prognosis if early and promptly treated. If the diagnosis is delayed, patient may develop substantial cognitive and behavioral defects ranging from mild to severe. In older children, the growth rate provides a good index of adequacy of the treatment. Thank you.